reread his bio. We are pleased to have Dr. Nico Singh with us, and he will be discussing transcranial magnetic stimulation therapy, or TMS, which is an exciting treatment option that has emerged for the psychiatric community. Using highly focused magnetic pulses, this non-invasive, non-drug treatment stimulates areas of the brain known to control mood. Such a therapy may represent the future of neurological and psychiatric treatments. Today, you will learn the basic principles of TMS therapy, how it can be used, and the latest research on disease and what it states that it treats. Dr. Singh is a leading psychiatrist in Washington, D.C. and Northern Virginia, and has had extensive experience in both inpatient and outpatient settings. He founded Tysons Psychiatry in 2008, a private practice in Virginia, which provides care for individuals, couples, and families. Dr. Singh serves as the medical director for both Integrated Clinical Concepts and the Center for Transcranial Magnetic Stimulation, known as TMS Neurohealth. He is also a consultant to Advantage Healthcare Systems, serves as faculty at 2 schools of medicine, and speaks throughout the United States. We welcome you, Dr. Singh, and thank you for talking with us.
Thank you so much for that wonderful introduction, and it's my pleasure to be here. And while we work on getting the slides, I'm going to go ahead and get started, as you mentioned. And what I'd like to do is before even I go into my slides, and while we hunt for them, no worries, before I even go into the slides, one of the things that I was thinking about commenting on to the audience that's out there, to the attendees, is giving them an update on how we're thinking about the treatment of mental illness and neurological ailments in general. So I'm going to start off by giving a synopsis of where the paradigm seems to be shifting. It seems these days that with the advances in neurobiology and neurosciences in general, we're beginning to look at pathologies and disorders not necessarily in the same way that we're looking at them now, which is as syndromes, right? So take, for example, the classic psychiatric disorder, depression. Depression is a constellation of symptoms, including concentration and focus, fine, which comes from where? The prefrontal cortex part of the brain. It's a cluster of mood symptoms, dysphoria and suicidality, and these types of things, which come from where? More like the limbic system of the brain, the amygdala and the hippocampal areas and these types of things. Circadian rhythm, so sleep disturbances, and motor disturbances in terms of affect, such as crying and tearfulness and what have you. And those are looking at more from the motor cortexes and in the cerebellum of the brain. So really, as neuroscientists now, we're looking at treating illnesses, whether they be neurological or psychiatric in nature, and looking at them more as domain-based ailments, where if you think about it conceptually, the concentration and focus problems of depression are the same concentration and focus in anxiety, the same concentration and focus deficit in narcolepsy, same concentration and focus deficit in epilepsy. I mean, you name it, it's still the same concentration and focus problem that's structurally coming from someplace like the prefrontal cortex. So with that being said, the paradigm is shifting towards looking at the brain in totality and the different parts of the brain not necessarily being able to communicate with each other in an effective and efficient sort of way. So the research is now shifting towards these domain-based classifications of disease, and domain meaning certain regions of the brain that are responsible for certain functions, and trying to understand where that disconnect is, where the communication isn't correct, and we're getting a hodgepodge of symptoms where when you look at its origins, they're coming from different regions of the brain. So with that being said, a lot of our approach to treatment, whether it be pharmacologic or otherwise, has shifted towards looking at circuits in general. So circuitry, if you can understand, is actually brain connections, right? So a circuit goes from one point to another point and communicates information. So even pharmacologically, we're looking at brain circuits, but certainly we're looking at brain circuits more from a neuromodulation perspective. Now, what the heck do I mean with that? And this is where I really start talking about transcranial magnetic stimulation and why it makes so much sense. So I'm going to start off by just letting you know that the concept of magnetic stimulation has been around for a very long period of time. And truth be told, TMS, transcranial magnetic stimulation therapy, as we know it now, has been probably under investigation for about 20+ years. What we were trying to do is trying to identify the correct neuroanatomical locations where we would be able to utilize the magnetic pulses provided in an efficient and safe and tolerable way in order to treat a disease state like depression. We finally have found it for depression, and that being said, looking at many different disease states which we can affect using transcranial magnetic stimulation. But right now, I want to just clarify that transcranial magnetic stimulation is only FDA approved for treatment-resistant depression. And I think that's very important to know. Yes?
Dr. Singh, I do apologize for interrupting. I'm glad that our guests on the webinar were aware we were going to do this. I just wanted to ask you, give you the instructions when you're ready. You can click on your PowerPoint presentation, and then there should be, now that you are the presenter, there should be a button that says show my screen, and that'll enable the rest of us to see your screen.
Yeah, so I have here on here, show my screen. Okay, great. And
the PowerPoint should be coming from your laptop, not from our office's laptop or your computer.
I see. Okay, should be coming from my computer. Got it. I'm wondering, my fear is that it may not be on my computer. I think we might have been under the impression that it was going to be synced in cyberspace-wise. Ooh, that could be a problem.
Well, let's go ahead and continue with the presentation, and then I will, what you provided already is so absolutely wonderful. Go ahead and continue with your presentation, and then I will make sure that we post the webinar with the slides for those who wish to revisit it on our website at a later date. So I think that's a terrific solution, and we'll just, because we do only have another a certain set amount of time, that we'll go ahead and just continue with the presentation.
Sure. Great, we'll do it that way, absolutely. This is good. So that being said, we're going to go ahead and start talking about transcranial magnetic stimulation, because I know I've already confused you enough, but I'm going to go ahead and now focus it down on transcranial magnetic stimulation. And where I'd left off was TMS being FDA approved for major depressive disorder. So one of the things that I'd like to start off any conversation regarding TMS is looking at major depressive disorder in totality and its respective treatments, right? So categorically, what are the treatments that we use for major depressive disorder? Well, categorically, treatments for major depressive disorder include pharmaceuticals, right? The Prozac, Paxil, Zoloft, Celexas, Brintellix, Vibrance, Cymbalta, Effexors, Prestige, the Wellbutrin, the Remrons of the world. And I know that you know, if there's any prescribers in the audience, I know you've prescribed all of those medications. Certainly, if there's anybody who's taken those medications, you've known that they can be effective. They can come with a lot of side effects as well, but also they can be wonderful therapeutic interventions. Certainly, let's not forget psychotherapy, remarkably useful in psychiatry. I mean, cognitive behavioral psychotherapy has actually shown to cause the certain degrees of neuroanatomical changes in the brain, yes, indeed, a rewiring of the brain where your thought processes are more appropriate and more online, which is wonderful. But more recently, the paradigm has started to shift more towards technology-based interventions, such as TMS, which falls under the category of neuromodulation. What are the different types of neuromodulation techniques? Well, transcranial magnetic stimulation is a leading one at this point. Previously, there was a neuromodulation technique that's unfortunately fallen out of favor called vagal nerve stimulation. Deep brain stimulation is actually a blossoming field right now, in particular in the treatment of OCD and Parkinson's type symptoms, but it does unfortunately require neurosurgical intervention. And then, of course, the neuromodulation technique that's been around the longest, and you all have heard of this, which is ECT, electroconvulsive therapy, sometimes called shock therapy, where a seizure is being induced in a patient, and it is done in a post-anesthesia care unit in a hospital setting with an anesthesiologist who's present to anesthetize the patient. And then essentially what's happening is that electrical currents are being sent into the brain, sparking the brain into a opening of the ion channels, causing a epileptic episode. And the theory behind it is, and I'm being very conceptual here, the theory behind it is that when those ion-gated channels close and all of those all of those ions now actually have a chance to realign themselves, and therefore the conductivity of the brain is more appropriate, and therefore the processing in the brain is also more appropriate. That's the concept behind electroconvulsive therapy. Deep brain stimulation does involve neurosurgery, where basically you're going in and placing a magnetic or electrical stimulus deeper into brain tissue that cannot be reached from a very superficial or cortical perspective, and so you have to go in and place that in to stimulate a certain region of the brain that you're interested in stimulating. Vagal nerve stimulator was where there was a stimulator placed next to the vagus nerve, which actually runs parallel down near the heart area, which actually had a lot of noradrenergic, meaning norepinephrine type of control, and was able to help with depressive symptomatology, but unfortunately it hasn't really shown much utility at this point in time. And then, pun intended, the wave of the future, which is transcranial magnetic stimulation. So let's talk about transcranial magnetic stimulation. What is it? Transcranial magnetic stimulation is premised around, well, essentially the rules of biophysics. If you all remember a guy named Michael Faraday, and he came up with a law where he basically said that if one were to take a gentle magnetic field or even a powerful magnetic field and place it next to any sort of conducting material, what would happen? Basically, you'd get a spark. So basically, if I were to take in a real-world practical demonstration, if I were to take a magnet and bring it close to a live wire, I would actually get a gentle spark in that live wire. And so then now we as scientists looked at this and said, well, we know that the brain is actually all about conductivity, so is there any way that we can affect the brain in a very reasonable way using magnetic fields to exert a desired effect? So affect the brain, A-F-F-E-C-T, to exert a desired effect, E-F-F-E-C-T, such as the control of disease states like depression, Parkinson's, OCD, et cetera, et cetera. And indeed, we absolutely can. We've now discovered that we can. And you know, to basically explain why this would make sense conceptually, in basic neurosciences, there's something called long-term potentiation. And long-term potentiation means that basically that essentially, if we can get neurons to fire more in sync, then we have a high likelihood that they're going to be efficient and productive. So basically, it's one of those things where neurons that fire together wire together, and that's important in things such as learning, in terms of mood regulation, and overall in general in terms of communication of information. The opposite is long-term depression, which right now is, we're not going to get into the details regarding long-term depression, but long-term potentiation is the key. And so now if I have a group of neurons that are not necessarily in sync the way that they should be, and they're not communicating information effectively, and remember this ties back to what I started off our conversation with, this paradigm of neuronal circuits and different parts of the brain being able to communicate effectively with each other. But if I'm able to use a magnetic field to create electrical currents, which then will spark neurons in a row to fire in sequence, now all of a sudden they will start to learn together, they will fire together, they will wire together, and now I have effective communication throughout different regions of the brain. Okay, fine. So we're still talking about Faraday's law, we're still talking about long-term potentiation, great, but how does this translate into the practical real-world therapeutic intervention called TMS? And I'm going to dive right into then what TMS essentially does. So TMS, it basically, what I've learned and what we've learned through neuroanatomy and neurophysiology is that the emotional centers of the brain, the limbic system, are buried a little bit deeper than we would like in order to be able to affect changes in them. But then is there any other way that we can actually reach the limbic system of the brain and help it perform more effectively? In other words, the neurons in the limbic system of the brain are not creating enough serotonin, norepinephrine, or dopamine. How can I actually spark them into a wakefulness? Well, one of the things that we learned is that there's a region in the prefrontal cortex, which is the top front superficial part of the brain. Superficial part of the brain, this is important. called the left dorsolateral prefrontal cortex. And you don't have to memorize that name, the left dorsolateral prefrontal cortex. If I'm able to actually place a very gentle magnetic field, great, so in the form of a magnet that comes to the left dorsolateral prefrontal cortex, and I go transcranially right across the cranium, right across the bone, and stimulate that superficial outer surface of the brain, am I able to affect the limbic system? And indeed I am. We've learned now that neuronal circuits from the left dorsolateral prefrontal cortex actually go down many different pathways, one of which actually goes down into the emotionality center of the brain. Now, if you think about like a firecracker, if I light a spark at the tail of a firecracker, that thing's going to go, 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 go until it actually reaches the firecracker, and the firecracker explodes into space. The same thing here. If I put a gentle magnetic field in the left dorsolateral prefrontal cortex, that electrical spark is going to run very gently down into the limbic system, and it's going to spark those neurons into a wakefulness, essentially saying to these neurons, dear neurons, you have been underperforming, you have been underfunctioning, you're not creating the appropriate amount of serotonin, norepinephrine, and or dopamine. Let's get with it, guys, very conceptually. So essentially so electrically what I'm doing is sparking these neurons into a wakefulness, enhancing the production of these critical monoamines that are responsible for depression and anxiety symptoms, and also concentration and focus symptoms, for example. And how do I do this? Well, how do I identify where this left dorsolateral prefrontal cortex is? Well, the way that I'm able to figure it out, because remember that there are certain variabilities between different people, is that if I stimulate a region of the brain called the motor strip, and it's called the motor strip because when you actually activate, and luckily, like the left dorsolateral prefrontal cortex, is located on the very top surface of the brain, so you're not necessarily pummeling a magnetic field very deep into brain tissue, because that can cause a lot of problems if you're going, if you're sending a magnetic field and you're affecting a large mass of brain tissue as opposed to being much more focal, much more localized. The motor strip is actually located on the top part of the brain. And I can actually use my magnet very strategically to try to get my patient to have a spasm or a twitch of the thumb. And if I can find that spot on the motor strip, that piece of the brain where that thumb is twitching very nicely, very gently, then I'm in very good position to be able to find the left dorsolateral prefrontal cortex, because approximately 5.5 centimeters anterior, meaning towards the front, is where the left dorsolateral prefrontal cortex lies. So find the motor strip, get the thumb twitch, wonderful, move the magnet about 5.5 centimeters to the front, and that's usually where the left dorsolateral prefrontal cortex is. It doesn't have to be perfectly precise, because remember that magnetic fields are like cones, so they actually will expand out as soon as they leave the magnet, and you will certainly be able to hit the sweet spot of the left dorsolateral prefrontal cortex. Now, going gently across the cranium and touching just the superficial aspect of the brain is remarkably useful in this, because I'm not really causing too many problems. I'm not necessarily causing too many side effects here because, well, I'm not stimulating a whole lot of tissue. All I'm doing is just touching one spot at the very top of the brain. Then I let the brain do its own magic, where essentially then it runs down into the limbic system, and voila, you get a nice spark of wakefulness for these neurotransmitters. That being said, I should not be neglectful in thinking that if I'm stimulating a piece of brain tissue, isn't there anything that's happening right then and there at the left dorsolateral prefrontal cortex level? In fact, there is. This is the beauty of TMS, because at the prefrontal, at the left dorsolateral prefrontal cortex, the direct depolarization, the firing of the neurons stimulated by the magnetic field, causes a lot of action potentials in the neuron, and basically you also get dopamine and norepinephrine release in the prefrontal cortex also, which is critical for depression, right? Because down in the limbic system, the emotionality center, that's just one piece of the equation. The prefrontal cortex, which is your executive center, your rationality center, right? Your concentration, your focus, your rationality, that too is affected in depression. And look at that, through transcranial magnetic stimulation, I'm also sparking those local neurons into a wakefulness, and therefore conferring benefit right then and there at the site of the magnetic stimulation. So if I'm a patient and I decide I want to go through TMS therapy, what are going to be my expectations, right? So, I mean, am I going to have to go to the hospital? Am I going to need an anesthesiologist? Am I going to have memory loss like I would with, say, ECT? Am I going to have an implanted device in me? No, that's absolutely not. And the way that I've described it to people, it's when patients have asked me, I've essentially said it kind of looks like you're walking into either a dentist chair and sitting down, or the Starship Enterprise, Captain Kirk's captain's chair, and you're sitting down over there. You've got your TV going, the home and garden television, for example, if you wanted to watch that, whatever the case may be. And essentially what happens is that the magnet sits on the left dorsolateral prefrontal cortex, and it launches a pulse, or a train, if you will, a train of pulses, about 40 pulses that you get in each train, and then it pauses for 26 seconds. It gives the brain a chance to rest, basically. So you take a nice little pause in between trains of pulses. So essentially what happens is that you're sitting over there, you'll get a 4-second train of pulses, and that'll be about 10 pulses in a second, so about 40 pulses of magnetic stimulation, and then about 20 seconds of nothing, and then once again you'll get another train of 40 pulses over the course of 4 seconds, and then about nothing. And how much time total will you be spending in the chair? Roughly about 37.5 minutes. So really what I tell my patients is plan for an hour. You can come in your suit, come in your dress, come in your jogging gear, come in whatever it is that you are in. You sit down, the magnet does its work. An hour later, you're out, and you are able to go right back to exactly what you are doing for that day. So really unencumbering to lifestyle, except that possibly this may be an impact, but a full treatment course of TMS is about 5 days a week. So one does have to receive TMS treatment. And remember, because when you're sparking things into a wakefulness, you want to also be able to maintain that spark and ingrain that response. So roughly 5 days a week, about 1 hour a day. And the usual treatment course is about 4 to 6 weeks, with the potential of doing a taper, meaning going down to, instead of 5 treatments a week, going down to 3 treatments a week, 2 treatments for a week, and then down to just 1 treatment, and then calling it a full and legitimate treatment course. In my practice, I'll tell you, I've probably seen treatment response usually within about 2 to 3 weeks, sometimes 4 weeks for patients who are delayed responders. But certainly by week number 4, 5, and 6, we do tend to see response pretty nicely occurring at that time. Are there people who don't respond to TMS? There are, of course. Any sort of therapeutic intervention is not going to be 100%. So what I'd like to do now, since I've shifted towards looking at the delivery of TMS, let's talk about some of the research studies that were done with TMS, and really who's a responder, who's not a responder, and what do the numbers really look like. So in the pivotal trials that got TMS FDA approved, it was actually quite remarkable. It was studied in the adult population, age 22 to 70. And the median number of antidepressant treatments per the FDA population that was looked at, the median number of antidepressant treatments was actually 4. So patients have been on 4 different antidepressants, but it ranged from as little as 1 to all the way up. I think a couple of the patients, or maybe one of the patients in the pivotal trials, had upwards of 23 different antidepressants that they had tried. The most robust results with TMS happened to be correlated with patients who had tried 1 full antidepressant course and hadn't succeeded, and then went right into the TMS therapy protocol, and they had very powerful and robust results. And the MADRS score, Montgomery-Asperger's Depression Rating Scale, is a measurement tool that we use in psychiatry quite a bit, and it's the gold standard for depression and depression-based research. In the pivotal trials that were done by Neuronetics, the company that actually makes one of the machines that's FDA approved right now and on the market to deliver TMS, the change was quite remarkable. As early as honestly week 2, week 3, week 4, and week 6, there was a significant change in the Montgomery-Asperger's Depression Rating Scale compared to placebo. So really nice therapeutic response. They also used a second depression rating scale called the Hamilton Depression Rating Scale as well, and that's separated from placebo very nicely as early as week 2 all the way through the study period of week 6. So that makes sense. That's how this protocol actually came about. 6-week-long protocol, and congruent with kind of what I was saying, seeing response as early as week 2, but week 3 and 4, you really start to see material changes in how in how people are feeling who are undergoing TMS treatment. One of the things that a lot of patients ask me, they'll say, but what about maintenance of response, right? So what's going to happen? Let's say I undergo TMS treatment. Am I going to be able to maintain that response? Great question. The research studies are still being done more extensively because TMS has really gained traction in probably the last 2 to 3 years, I would say. And so as a result of that, we don't necessarily have a lot of good data yet on how powerful the treatment response can be, and if there are any sort of predicting markers as to whether a patient is going to be able to maintain that response or not. What we do have is a 6-month-long follow-up study that was done where patients who were treated with TMS therapy and were responders, about 14% of those patients did relapse before the end of 6 months. About 38% experienced symptom breakthroughs for depression, but they were able to, about 85% of those patients were able to respond to the reintroduction of TMS quite nicely. So the data matches up fairly well with other types of therapeutic interventions in terms of maintenance of response. But truth be told, I'm really excited to see future research that's going to be done in terms of being able to look at how powerful the impact of TMS is going to be in being able to sustain remission. The other thing is also that in development are a lot of protocols looking at possibly automatically having built-in continuation and maintenance phases for TMS. So if some of you out there are already familiar with ECT, if not, not a problem. Basically what a lot of the standard operating procedure is with shock therapy is that patients will go through an acute course of 12, 14, 15 treatments, whatever it is that they need in order to have a significant response and reduction in their symptoms. And then what they'll do is they'll go through a continuation phase where they won't be having ECT therapy 2 or 3 times a week, but rather once a week, for example, for a few months, and then they'll drop down to 1 ECT for a few months as part of a maintenance phase. That same concept is being looked at TMS, and in our centers here in the Northern Virginia area, we've actually seen remarkable success in maintenance of response. So while it's not a formal research study, but based on our own clinical experience here in Northern Virginia, we're seeing that maintenance TMS therapy has been remarkable in sustaining the response from the acute full course that was received up front. One of the questions I also get asked quite a bit from a lot of people is saying, hey, we talked about how our knowledge of neuroanatomy, our knowledge of neurophysiology is so critical in being able to treat disease states, and for depression we have this wonderful merger of understanding neuroanatomy and neurophysiology, and we're able to affect patients suffering from depression. What about for other syndromes? And that kind of makes sense. It's a very legitimate question, because if we're talking about the brain and neuronal circuitry being disconnected and not being able to effectively communicate with the different parts of the brain, not being able to communicate effectively with each other, you are going to get significant dysregulation, and there's going to be a lot of neurological symptoms that will, neurological diagnoses actually, that'll occur as a result of this neuronal disconnect. So TMS is being looked at potential other uses. For example, in post-traumatic stress disorder, right-sided TMS is being used. In depression, the magnet is usually placed on the left side, and the frequency of the pulses is considered high frequency. So anything above 5 hertz is considered a high frequency. So the treatment for unipolar depression, major depressive disorder, is left-sided high frequency treatment on the left dorsolateral prefrontal cortex. But PTSD, there's been some research that's been done looking at high frequency also on the right side of the brain instead. Bipolar disorder, unfortunately, there have been some small research studies, nothing significant, but small research studies that have been done on bipolar disorder and TMS, particularly looking at bipolar depression. And in randomized clinical control trials up to date, there unfortunately hasn't been any sort of significant robust results in randomized clinical control trials. Open label studies and open label reports have shown that there's some modest benefit in depression, but remember that when you're talking about open label studies where basically the investigators are aware of who's getting what and what have you, that's not technically considered a scientific study. And so open label studies have shown modest benefit, but the legitimate, true scientific studies of randomized clinical trials, unfortunately right now have not shown any sort of significant impact on bipolar depression. On mixed episodes, there's a possibility of looking at low frequency stimulation at the prefrontal cortex, at the dorsolateral prefrontal cortex. Low frequency. All right, so what is this guy, this TMS guy talking about low frequency? He just got done saying everything was high frequency, right? Well, the theory, and this is going back a little bit to biophysics, the theory is that if you have high frequency stimulation, then what you're doing is you're exciting that neuronal tissue. So it causes an enhancement of activity. So the prefrontal cortex, you want to enhance that activity definitely by using high frequency for depression, because depression is a subdued state of existence. Now, when you're talking about things like anxiety, and when you're talking about possibly mixed episodes of bipolar disorder and/or you know, and as I mentioned before, anxiety in general, which are actually hyperactive states of the brain, it's now been shown that in general, and this is not gospel yet, we still have more investigations to do regarding this matter, but in general, low frequency is somewhat inhibitory to brain tissue. So if I have somebody who's in a hyper-excitable state of existence, whether it be obsessive-compulsive anxiety or a mixed episode of bipolar disorder, for example, I'm going to want to do low-frequency transcranial magnetic stimulation in order to slow that brain tissue down. So we're looking at bipolar, manic, and mixed episodes right now quite extensively. The other thing that I get asked a lot about is dementia. Is there been any research? Is there any impact on TMS and dementia? There's been some studies that have been done. Modest benefit at best, but once again, I'm very excited to see what the future holds in terms of research studies here. Modest benefit at this point. High-frequency bilateral TMS is probably going to be the way to go with this. The thing about dementia, and it also, of course, is going to depend on which type of dementia we're talking about, but in general, when you're talking about cognitive decay, you want an enhancement of the neurotransmitter acetylcholine. You want an enhancement of the neurotransmitter dopamine, and you want an enhancement potentially of the neurotransmitter histamine as well. Now, those are very sophisticated pathways in being able to affect. They're not nearly as direct as, say, giving a serotonin reuptake inhibitor, enhancing the experience of serotonin, or giving a norepinephrine reuptake inhibitor and enhancing norepinephrine that way. The enhancement of these other neurotransmitters has to be done in a very roundabout sort of way. So that's why I think bilateral TMS therapy is going to be important in dementia. But as it stands right now in terms of the state of research, it's only shown modest benefit. But I think that there's hopefully much more to come on the horizon. There's been some work done in schizophrenia as well with TMS, but right now, again, very moderate effect sizes, nothing that we can really hang our hat on. ADHD, there hasn't really been any data done yet, but again, this is something that a lot of investigators are going to be looking at in the future. OCD right now is really reserved for deep brain stimulation. That's been shown to be powerfully effective in treating obsessive compulsive disorder, but I'd be curious to see if we can find any sort of algorithm in terms of frequency, in terms of hertz, where we can affect OCD, quite possibly. But that being said, right now we don't have any legitimate protocols for those type of disease states. So for depression, that's the gold standard for transcranial magnetic stimulation at this point in time. The nice thing, why would anybody ever choose TMS? And then I'll also answer why would anybody not choose TMS? One of the reasons why people would choose TMS, number one, it's not systemic. It's very localized, right? So it's just stimulating the left dorsolateral prefrontal cortex, and that's it. You're not taking a pill or a medicine that's being distributed systemically throughout your entire body, And so you don't get those systemic side effects. You're not going to get the fatigue. You're not going to get the sexual side effects. You're not going to necessarily get any sort of weight gain issues. You're not going to get any cognitive fogginess, et cetera, et cetera. So none of those systemic side effects. And of course, there's no drug-drug interactions either. So whatever other medications you're taking, TMS is not going to interfere with any of that. So no systemic side effects, no drug interactions, no adverse effect on cognition. And so that being said, and it's very convenient in that you don't necessarily have to take time off from work other than to maybe transport to the center, sitting in the chair for 37.5 minutes, and then transport back, and you're able to resume your day. There's no loss of memory. There's nothing of that nature. There's no change in your lifestyle in that regard. What would be the most common side effects then? Perhaps the reasons why one would not necessarily want to do TMS. Well, you definitely don't want to do TMS if you have any sort of ferromagnetic material in your cranium. Ferromagnetic material in your cranium, like titanium plates or anything of that nature, because if we're bringing a magnet to your cranium, the last thing you want is that metallic object that's in your cranium to then be affected by the magnetic field. So number one, it's a contraindication. If anybody is asking about going under TMS, I always make sure that there's no implants or anything like that. In general, for the most part, there is caution with pacemakers and what have you, but otherwise, for the most part, that's also okay. You just have to clear it with the cardiologist, but in general, we want to just make sure that the TMS is not going to interfere with any pacemakers. Risk of seizures, for example, in the research studies, the risk of seizures was about 0.1%, so 0.1%. Nonetheless, I always like to ask people if they have a family history of epilepsy or if they themselves are epileptic. Truth be told, it's really if only they themselves are if they themselves have epilepsy, not necessarily so much the family history. Those would probably be about the only reasons why one would not necessarily get TMS therapy. One could also look at TMS therapy as first line in the context of pregnancy, where medications may be contraindicated, and you don't want to risk any sort of pharmaceutical exposure to the fetus. Those would be another opportunity, obviously, for TMS treatment as well. Okay, so with that being said, I've actually talked quite a bit, and I've gone through just about everything that I had on my slide deck pretty quickly, but one of the things that I've learned is anytime and every time that I'm talking about transcranial magnetic stimulation, there's usually tons of questions. So if it's okay with you, should I open it up to questions at this point?
Absolutely, Dr. Singh. I did send a message to folks that if they had questions to go ahead and submit them. Some of the questions you have already answered, but I'll just go ahead and repeat them, and if you feel that we have already answered them, we'll just move forward. Okay. So one of the questions was from someone asking, what is your experience with theta burst along with TMS?
Oh, yeah. So, right. So theta bursts. And can you be more specific in terms of the experience? Like, is this a question regarding the theta bursts in general, or and I'm not sure I necessarily can follow what the question is asking. Do you have access to the person who asked the question?
I do, and I can ask this person to answer more specifically. So if we just all hold, we'll see if this question came from someone with the initials EM. And so if EM is still on the line, it would be great if they could type an question that's more specific.
And while we're waiting for that, so theta burst stimulation, just for the audience, theta burst stimulation protocols, they consist essentially of very high frequency, approximately 2,500 hertz pulses delivered in 100 hertz bursts and in 5 hertz intervals, which is really consistent with theta rhythm, when you look at it through, when you measure it through electroencephalographic studies, which are EEGs essentially. So theta burst stimulation protocols, they're pretty neat. They can be divided into two main categories, intermittent and continuous, with the effects being either excitatory or inhibitory, to be quite honest with you. And intermittent theta burst stimulation is defined as what is like, I think it's about 1900 milliseconds of stimulation repeated every 10 seconds for a total of, I think it's approximately 200 seconds in general. But they remain relatively investigational at this point in time, and with the main potential advantage being that similar effects are basically, the advantage is very similar to TMS, RTMS, which is what we talked about today, but you can achieve those effects considerably in a considerably shorter period of time, shorter protocols, and so essentially you can potentially get very similar results, but in a much more compact amount of time. That being said, I'd be excited to see what becomes of this, to be quite honest with you, but right now it's not really considered, it was certainly not FDA approved, but and it's still relatively investigational.
Hey, Dr. Singh, the person who had asked the question felt that you did answer it, but states that their doctor had positive experience using theta burst with those with their loved one that had bipolar disorder.
Great. So good, a good outcome. Yes.
I have another question for you, and again, we'll hope that it hasn't already been answered. But what is the long-term prognosis if a patient has experienced a good result and suicide? I hope I'm saying this correctly. Suicidality is gone, and the maintenance program has been completed.
And the maintenance program has been completed. Okay, so that's going to be a very subjective answer. Then there's no research studies that have said, okay, what is the maintenance of response in a person who has had a therapeutic response to the initial acute impact of TMS, and then also has gone through a maintenance phase, and then the maintenance phase is complete. So now it's a very sophisticated question in that you're asking. It's many layers that have already been done. For example, in my personal experience, so no research studies that I can speak to per se, because right now the research studies, to be quite honest with you, are looking at, hey, if somebody gets a response at the acute intervention level, how long does that response last? And they're trying to figure out then, based on that, what should a maintenance phase really look like? And many different centers and authorities have different ideas as to what it should look like, but there's no legitimate uniformity yet. And so this question is saying, and never mind all that, gone through maintenance, hey, how long is this going to last? Subjectively, in my opinion, based on what we've seen here at our clinics, it's actually a very good prognosis. I think it's very intelligent, in my personal opinion, to go through the acute phase, and if you've got a great, robust response to TMS, fantastic, don't lose it. Not that you necessarily would, but don't lose it. It's important to go through a maintenance phase to solidify even more that response. And we've seen that in the patients who have elected to do so at the TMS centers. We rarely hear back from them. I mean, maybe we'll get a handful of patients who may have a recurrence of symptoms and maybe would have never even relapsed, but just that fear or warning signs of depression coming back have triggered them to contact the clinic and say, hey, let me just get back on my maintenance program again. Fine. Some people have elected to just want to do the whole treatment course again. Fine, not a problem, but I'll tell you, it's rare. So in my humble opinion, to answer the question, it's a very good prognosis.
Singh, before we take our next question, I did want to just reiterate again for folks that we did have some technical difficulty just now on our webinar today, showing the PowerPoint presentation, and would ask that you check back after next Tuesday on our International Bipolar Foundation.org website or IBPF.org website to check. We will do our very best to load the PowerPoint presentation in sync with the audio portion of this fantastic webinar today, Dr. Singh. The next question that we have time to pose to you is, can you undergo TMS with a dental implant?
Oh, yeah, great question, great question. So the experience has been at this point the type of implants that, that cavities and these types of things that the dentists are using are not necessarily going to be ferromagnetic. So we've had a lot of patients with dental implants who have gone through TMS. That being said, we still always reach out to the dentist, obviously with patient consent, and we find out exactly what the material is, whether it's conductive, ferromagnetic, and in what quantities is it located. But truth be told, in modern-day dental practice, they're not really using ferromagnetic material. So unless it's a special circumstance, in which it could be. So you must do your due diligence and reach out to the dental practice and find out exactly what material was used for the implant. But 9 out of 10 times, or 99 out of 100 times, it's not going to be a problem.
All right, and Dr. Singh, one of our listeners or participants, attendees today, has stated that perhaps this type of therapy is more common in Europe. Can you speak to that?
I think there are a lot of things in Europe that are a lot more common than here in the United States of America. I think the European FDA also tends to be a little bit more, or excuse me, I think the American FDA, if there's anybody out in the audience that's an FDA person, I apologize. They tend to be very, 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 very tight here in the United States of America. In terms of treatment with TMS in Europe, yeah, I think that TMS, electromagnetic stimulation in general, and using these type of therapeutic interventions has been more common in Europe, and I can certainly say that in Japan. Actually, I think the largest TMS center is located in Japan, in fact. So in the U.S., we've been a little bit slow on the uptake in terms of neuromodulation. I don't know the exact numbers, for example, but I am not surprised that the international community is ahead of us in using neuromodulation.
We do have a few more questions, and we have about 7 minutes left on our webinar time. So if anybody does want to submit another question or two, we will do our best to get Dr. Singh to answer those. The next question is there a risk of increased manic phase in use of TMS for a bipolar patient?
Yeah, so it's only anecdotal case reports of that. I was talking to a clinician the other day who said that she did have a case where the TMS, so in a bipolar patient, right? So if a patient is diagnosed as bipolar and you're doing TMS and you're trying to treat the depressed phase of bipolar with TMS, is there a risk in somebody who is diagnosed as bipolar as causing a manic switch? The research studies didn't really pick up or detect any of that, any of the research studies that were done with bipolar, to be quite honest with you. But there are case reports out there where they have seen a antidepressant switch, and TMS being the antidepressant. But they're rare, to be quite honest with you. I think in large part because if you think about the concept of TMS is one where you're using very gentle magnetic touch in the superficial part of the brain, and you're using very gentle electrical stimulation, electrical spark going down to liven up the neurons. You're not really, you're not launching an ECT bomb, if you will, for lack of a better way of saying it. You're not, that's essentially not what we're doing at all. So the likelihood, the propensity for causing manic switches is relatively low with TMS. Can it happen? Sure, but it's only case reports out there. There's nothing really substantial in the literature suggesting that TMS is a switch agent.
And we do have another question. What studies have been done comparing TMS with antidepressants regarding effectiveness?
So no head-to-head studies, right? So there was never anything that took, hey, X number of depressed patients. Let's start this patient. Let's start, these patients on Prozac, and let's start these patients on TMS and see who gets better faster sooner. So no head-to-head studies that have been done. And remember that TMS's FDA approval is for treatment-resistant depression, meaning that the patients have already been on antidepressants and it hasn't worked. So a lot of the research, so in fact the FDA pivotal trial was for treatment-resistant depression. The question that's being asked is, hey, what if I were to use TMS first line? Would it outperform an antidepressant first line? And there really is no way to comment on that, in my opinion. if you think, but in terms of understanding the two mechanisms, the antidepressant molecules that we use now, and again very conceptually, are trying to make do with what we've already got. So at the junction between two neurons, our molecules are trying to block the reuptake, the reabsorption of the monoamine of serotonin, norepinephrine, or dopamine, and we're trying to enhance the exposure time of the receiving neuron to those monoamines. So we're trying to make do with what we've got, which is a deficient amount. TMS is looking at it from a very different way. TMS is looking at it and saying, no, why don't we go ahead and start producing the appropriate amount? So it's looking at it from a production level, whereas the antidepressants are looking at it from a let's enhance the experience of what we've got at this point. So again, no head-to-head studies that have been done. It's really tough to say which one would work better. It's two completely different mechanisms of action and two completely different approaches, production versus reuptake inhibition, for example. So there's really is no way to say. I'm a huge advocate for TMS, of course. I prescribe medications like water. I do have a private practice, but I also do TMS. I'm a huge advocate for TMS. I see no reason why one would take medications and risk the potentials for side effects, for example, even though there are a lot of sophisticated medications that are out there now, when TMS may work completely, and that's it. And you're talking about a treatment course, no systemic side effects, first line, FDA approved for depression, for treatment-resistant depression. I would try TMS first line, to be quite honest with you, but I can't comment on which one would work better.
Well, thank you so much. We have about 2.5 minutes left of our webinar time, and I'm not seeing any further questions. I do want to thank Dr. Singh for being with us today and for providing this wonderful, insightful information. Thank you to everyone who has joined our webinar, and do check back on our website, and we will have upcoming webinars in our webinar series that you will also enjoy. So again, thank you everyone, and do check the ibpf.org website for future webinars. Any parting thoughts, Dr. Singh?
I think my parting thoughts would be, really keep an eye on TMS and neuromodulation. It's going to be really a significant player in the way that we treat all neurological disease states in the future. So much so that I failed to mention in this conversation about TMS that the Neuronetics device is the first device that was FDA approved. There's also a second device by a manufacturer called BrainsWay that's on the market. There's a third device that's also coming out relatively soon, that's going to be FDA approved and hit the markets pretty soon as well. So first there was Prozac, then there was Zoloft, and then there was Paxil. So we're getting even more players in the field of neuromodulation and TMS in general. So please keep your eyes on TMS. It can make a difference in people's lives.
Dr. Singh, in the last minute that we have, we've neglected to answer a very important question about, do you see this being covered by Medicare?
Oh, it is. And so in our area, it is actually covered by Medicare, for example, Pennsylvania, Maryland, Virginia. So, yes, I do see it being covered by Medicare. Absolutely.
All right. Well, I do hope.
And Medicare has variations around different parts of the country. Yeah. So Medicare does have different variations, different parts of the country, different Medicare carriers have different stipulations, but no, in our area it's covered.
Well, thank you. I do hope that answers the question of the very patient webinar attendee who was waiting to have that covered, or that topic covered. One final question again, is it generally covered by most insurance plans?
So most insurance plans, the answer to that question is no. So the ones that I'm aware of at this point that are covering TMS is the Blue Cross Blue Shield, Anthem, and then I think depending on which part of the country you're in and what type of relationship they have, if one of the blues covers it, then I think all of the blues will cover it as well. But again, it depends on geography. It's really bizarre. And remember that commercial health insurance companies, Aetna, Cigna, United Healthcare, et cetera, they have their own medical necessity criteria. So whereas you, me, the FDA, the American Psychiatric Association, the American Academy of Neurology will sit down and say, oh yeah, TMS is appropriate for patients who have X, Y, and Z symptoms or in X, Y, and Z situations, the insurance companies will say, nope, forget all of that. We want, I don't know, they'll say 4 antidepressant failures plus 2 augmenting agents and continuous psychotherapy and not a candidate for ECT. So just because an insurance company may say that it's covered, it may not mean that they will cover it. So you always want to check with your insurance carrier to make sure. So the Blues are on board. I think United is getting on board pretty soon. Aetna has submitted TMS to their medical review committee for approval, and I think we're still waiting to hear on what they've decided. As I mentioned, Medicare does cover it in our area at least.
I am afraid we are indeed truly this time out of time. So again, thank you, Dr. Singh, and thank you everyone for participating.
Thank you so much.